am delighted to invite Dr. Sudhir Atri sir, who is a senior professor at Department of Clinical Hematology, PGIMS Rohtak. Can we have a round of applause for sir, please? Sir has done MD Medicine and DM in Clinical Hematology. Sir has written a lot of research papers, and specifically in Rohtak, sir has been a very helping hand for all the hemophilia community. I welcome sir on the stage. Thank you.
And good morning, Dr. Tholigas, ma'am. She has been my teacher at PGIMS Institution, New Delhi. And good morning to all of DNOs sitting here and all the persons who are involved in the society, ladies and gentlemen. Good morning to all of you. Today we will be discussing the newer perspectives regarding something in hemophilia, what is particularly newer perspectives. And it will be, I will say, it will be a two-way discussion because you all are learned persons. Our aim is not to teach you, but our aim is to discuss with you what are your problems which you are facing, and so that if we are able to help you out, that is our main purpose. And every year we are organizing some program with the hemophilia so that more and more awareness is created in the DNOs, and if there is any problem they are being faced by the DNOs, these problems can be solved at that. So today we will be discussing the newer perspectives in hemophilia management, practical aspects actually, practical aspects. What is as we know the current scenario in the hemophilia, people with hemophilia in India are roughly around 25,000. Or you can say 26,000. This is data of 2022. Now more and more patients are there. So it is, and hemophilia A is around 22,000. Hemophilia B is around 3,500, and with inhibitors 630 patients. And the important age group distribution is 19 to 44 years. That is the most reproductive age group basically. This is the disorders which is affecting this population particularly, and because this is the most productive age group actually in the individuals. So if the person suffers from any morbidity, or particularly morbidity is much more in hemophilia, so such patients are, you can say, burden to the society, to the family also. So our aim is that the morbidity has to be reduced to zero if possible. And how we can achieve this goal, we will be discussing that part basically. And out of this 45% of hemophilia persons fall in this group, and 49% hemophilia B again fall in this group. So high percentage of patients belong into the working and productive age group which are suffering from this disease, and they are having morbid condition basically. How the treatment of hemophilia management has transformed actually, how the treatment has transformed. This slide is showing in 1950s, for the first of all, the plasma or the blood products became available for the treatment of hemophilia patients. Before that, there was no treatment, and it was considered total fatal disease. If the patient developed hemophilia, it was totally fatal actually. But in 1950s, because of the availability of the blood and blood products, there is some improvement in the patients of hemophilia has occurred, though their life has not prolonged much, but at least the acute complications have been, you can say, taken care of by these products. Then came the factors actually, around 1960-1970, clotting factor concentrate which were produced from the plasma, which were produced from the blood, or you can say clotting factor concentrate, specific component factors you can say. Then again the other factors developed, and recombinant factor came 4 decades later. Then came the extended factors, recombinant factors may first generation, second generation, third generation, that the improvement has occurred in the factor itself actually, recombinant factors. Then came the era of, you can say, the other products, and now particularly there is the era of extended half-life factors as compared to conventional SHL basically, or which are called the conventional factor, or the short half-life factors which are in plasma derived, maybe recombinant actually. And then comes the non-factor therapies, particularly like emicizumab, poncizumab, which is in pipeline going to come, and then there is still much more development in the field of hemophilia, particularly now focus is on gene transfer. That is the only curative treatment for the hemophilia that is being, you can say, developed. So, because our aim is to cure the person if possible, our aim is to cure the person, but as of today, the gene therapy is not practically available, though it is being developed, you can say, in this development stage, but practically it's not available. So there are still a number of challenges in the management of hemophilia. As of today also there are challenges in the management of hemophilia. What are those challenges actually? Breakthrough bleeds. All of you know the patients comes to you with the breakthrough bleeds. Even if patient is a regular prophylaxis, such patients also comes with the breakthrough bleeds, but their incidence is less as compared to the person who is on episodic treatment. So one important challenge is breakthrough bleeds, and that has to be minimized actually. Second challenge is inhibitor to factors. If a person is on regular factor replacement, there are 30% chances of developing inhibitors, particularly in hemophilia A, and 10% chances of inhibitors developing hemophilia B. That is another challenge for the management of hemophilia. But just because to avoid this challenge, we should not restrain from using the regular factor treatment in such individuals, because now the treatment is also available for the person with inhibitors, whether they are hemophilia A, whether they are hemophilia B, though there is, you can say, some difference, but treatment is available for the patient actually. Then the quality of life. Ultimately, it is the quality of life actually which is being affected in the individuals, and that is our main aim. That is lifespan of the individual as well as the quality of life. Our aim is to maintain or to prolong our aim is to a person who is suffering from hemophilia. Our aim is that his life should be like a normal person, Only then we will say we are succeeding in the management of hemophilia patients. And adherence to the factor replacement therapy. Adherence, it is fault of the patient sometimes also, and sometimes faults of the, I will say, fault of the system actually. Why I am saying system? Because sometimes interrupted supply of factor is available. At almost you can say it is happening at our institution also sometimes, at even the district hospital also sometimes. So that has also to be avoided. Only then we are going to succeed in our goal. So now I am specifically focusing on extended half-life factors because these are available actually, and what are the advantages of the extended half-life factor as compared to conventional factors which are called as the SHL basically. So how we can increase the half-life of the factor, that is important. There are various ways actually, like Fc fusion with the Fc portion of the immunoglobulins, albumin attaching the albumin molecules, or the pegylation of the same factor, that is the conventional factor, the SHLA. If it is pegylated, it will convert it into the extended half-life factors. That is. And what are the advantages of the extended half-life factors? Why we want the EHL actually? What is the purpose? The purpose of the EHL will be, it decreases the dose frequency, most important. That is, so patient will have less visit to the center. He has to make less visit to the center. That is important, one important point. Second is, it will increase the compliance also basically. Like if a person, like we have to make one visit to the hospital per week, or we have to make 3 visits to the hospital, so definitely we will like to have 1 visit to the hospital. And that can also be reduced further if the home therapy is provided to the patients under supervision. Okay? So it will increase the compliance of the individuals, and again, once the compliance is improved, it will improve ultimately the quality of the individuals, quality of the person suffering from the hemophilia. So that are the advantages of the EHL factors. So you can say same benefits are there, that is few clinical visits, less need of the vascular devices actually, which are particularly useful in pediatric population basically, and less burdensome infusion also basically, schedules for the doctor as well as for the, you can say, the patient also, and it will increase the chances of taking prophylaxis, compliance with the prophylaxis. If today we counsel the family, sometimes it is very difficult. I will not say every time it is difficult, but sometimes it is really difficult. They will say we don't have time and why we should come. In such cases, it will be very easy for us to counsel the family. That is going to increase the compliance of the individual also for this. So potential benefits are same as we discussed. That is longer half-life. So acute bleeds may be managed with just 1 or 2 injections only, and I will show our data at PGIMS Rohtak basically, because we are using this. Patients will require fewer doses to control their disease, and prophylactic dose decreases from 3 times a week in case of hemophilia A, and in case of hemophilia B, from 2 times to even once a week, and even beyond that also basically. So extended half-life factor 8 is available, 9 is available actually. So extended half-life factor 8, however, its life is increased only from 10 to 12 from 19 hours or maximum 24 hours. And there is a problem with this. Why problem is this? Because factor 8 in our body circulates with the 1 millivalent factor. That is a problem. And 1 millivalent factor maximum half-life is actually this much. Beyond that, we cannot increase the half-life of the factor 8. That is a problem. But still, I will say from the 8 to 10 hours, 10 to 12 hours to 19 to 24 hours, that is also sufficient because it will decrease the frequency by almost 50%. And that's good enough, you can say, for the patient. And that is very more, you can say, effective in patients of factor 9 or hemophilia B, where the half-life of this factor is around 18 to 20 hours. Conventional, whereas their half-life is 96 hours, meaning thereby once a week is also as effective as you can see 2 times a week basically. So these are the products available actually. Extended half-life factor is available in 500 vial, 1000 units vial and 1500 vials. And at each center I will say we should have all the 3 strengths because in pediatric population we will need less doses and in adult population we will need more doses basically. So it is better to have all the 3 all the 3 products, that is products in all the 3 you can say the strength that should be available. These are the various factors which are available actually, and this is the international data. I am not saying honestly international data. So there is a 96% reduction in the annual bleed rate with weekly prophylaxis. 90.6% of bleeds were controlled with less than 2 infusions, that is acute bleed basically. Whereas this conventional factor, it requires usually 2 doses. Minimum 2 doses are required for the conventional factor in patients of hemophilia A, in patients of hemophilia B. Minimum 1 dose is minimum, but it may sometimes also require 2 doses basically. And no inhibitors were detected during this study. Inhibitors were not detected against this factor, EHL factor basically, but though we will say the data is, you can say we are using it for a short time. As of today, inhibitors are not there, but yes, later on there are chances of inhibitor development are there, but as compared to the SHL, still the incidence is very, very low actually. And so these are the different products actually these are available, and these are the data. So meaning thereby you can see the 90 to 96% reduction in the annual bleed rate, as well as the chance efficiency is around 90 to 95%, and less than 2 infusions are required to control the acute bleed. Because majority of the patients they present with the acute bleed as they are on episodic treatment, they are not on regular prophylaxis treatment. But our aim should be we should start the regular prophylaxis, or best term is regular replacement therapy rather than a prophylaxis, because this word is confusing to the bureaucrats or the authorities actually basically. So EHL factor 8 is available in the vial strength I told you. Out of this, at our institutions, 426 vials were of 500 units, 489 were of 1000 units, and 1525 vials were of 1500 units. Out of this 40 vials of 500 units, they were provided to the medicine casualty, because sometimes majority of times when patients comes in the, you can say non-OPD hours, he comes to emergency. So we have provided this while to the emergency also, so as to tackle the emergency situation, because daycare is working from the 8 to 3. After that, the hemophilia daycare is not working, so we are providing this strength to our casualty medical officer also. But there is only one problem I will say, that supply is actually interrupted. Supply is interrupted, that is the only problem. We have ordered the new, you can say this, stock also. But till now the EHL factor 8 we have not used in surgical department actually. There was no need, no surgery has not been performed with the EHL factor 8. It has been performed with the EHL factor 9. Total number of registered patients in our center is around 450, out of which are almost 50% are adult, 50% are pediatric patients. And I am giving data of adult patients basically. Out of this 250, 141 patients, they were given the EHL factor 8 as well as 9, and 131 patients are hemophilia A, and 10 patients are of hemophilia B out of this 141. 26 out of 28 patients who were on once weekly dosing of EHL factor 8, that is they were using earlier twice weekly. Earlier 26 patients out of 28 they were using twice weekly factor 8, and now with the once the EHL was provided, they are on once weekly treatment regime. So almost 50% reduction in the dosing frequency, and that is very good for the patients. Some patients were on twice. Some patients who are on twice weekly, they are managed with the just one dose also basically. So patient to patient also vary basically. Patient to patient also vary. Out of this, if we compare the HL versus conventional factor, 28 out of 35 patients were fortnightly dosing of HL factor 8. They were earlier using once every 5 to 7 days. That is, once every 5 to 7 days they were coming with it, and now they are using only fortnightly, means one dose every 2 weeks. That is it. Out of 45 out of 54 patients who were once monthly, they were using once monthly HL factor. Initially, they were requiring the 2 doses per month. So almost 50% reduction in the dosing frequency has been achieved with the HL factor 8, and that is very important. Extended factor 9. Since its half-life is 3 to 5 times actually, so once weekly is sufficient actually, once weekly. In our institutions, we have using this pegylated factor 9, it is still available. It is available in strength of 500 units. Out of 279 vials which were procured, 254 vials have been used till now. Some vials are there. We have ordered a new stock also for the HL factor 9 as well as factor 10. Factor 8. 9 vials, these were provided to the emergency patients, so as to tackle the emergency situation in the emergency patients. 8 vials they have used in the orthopedics department for a surgery, major surgery, and that surgery was basically the patient has fractured hip joint, and there was DHS was there, so a fixator has to be taken out. So fixator was taken out. We have given 2 doses to the patient. We have issued the vials, 10 vials to the patients. But out of this, there is only 1 dose was sufficient. Initial dose was 80 units per kilogram, and that has been given to the patients, and hemostasis was very good. It was so good that patient does not require the second dose of the factor. It was so good actually. So now this is the current data. Out of total 10 patients of hemophilia B, patients on once weekly are 1 patient is on once weekly dosing. Once fortnightly are 4 patients are requiring the factor EHL factor 9 every 2 weeks, and 5 patients they are just on once month, and they are very happy that there is no recurrence of bleed in such patients. So EHL versus conventional, one patient, I already told, 1 patient requiring twice weekly replacements, now on once weekly dosing. 4 patients requiring every 6 to 8 days, or weekly you can say roughly can complete. They are requiring the every fortnightly, and 5 patients just 1 month. They are requiring a single dose at the monthly interval. And this slide is this older one. This is very important. That is, if we compare the regular primary prophylaxis or regular versus episodic treatment, look at the life expectancy of the individuals. If we are able to provide this treatment to the patients, only then we can expect a disabled free person with a normal lifespan, and that should be our aim actually. That is why in every meeting we are emphasizing that the patient should be given a regular prophylaxis, regular replacement therapy. That's the best term you can say, regular replacement therapy, because our aim is to prevent the occurrence of bleed actually basically. That is our aim. Even if I am not able to issue primary prophylaxis, secondary prophylaxis and tertiary prophylaxis also are very good actually. At least we should be able to do the second or the tertiary prophylaxis if we are not giving the primary prophylaxis. But our aim should be primary prophylaxis, and if we work together, that is the nodal center as well as the comprehensive care center, if we work together, we can achieve this goal, and that is our main aim in patients of hemophilia, because we want disabled-free India and disabled-free the hemophilic person. That is all. WHF is also recommending actually, World Federation of Hemophilia also recommend people with hemophilia receiving factor concentrates who would benefit from optimized prophylaxis. They recommend individual pharmacokinetic monitoring. I told you individual meaning some patients are just requiring the monthly doses, some patients fortnightly doses, some patients weekly doses. So that is also you can say individual based treatment, and we can come to know from the patient's bleeding profile actually. That is. For patients with hemophilia A or B, there is no evidence for clinical safety in person with hemophilia to recommend a preference over various mechanism of actions used to extend the half-life. So different pegylation, FC fusion, albumin, but most data is with the pegylated protein, pegylated factors actually. That is why we are preferring the pegylated factors. Most data, Roche data is with the pegylated factors. WHO recommends that the patient with hemophilia with an inhibitor should be considered for regular prophylaxis to prevent the bleeding episode. That is, but inhibitors that will require different kind of treatment. So to conclude is there is significant decrease in overall factor requirement and frequency of administration by about 50% in patient of hemophilia A, SHL versus the EHL if we compare the data. This indicates durable, and even the results are much better in patient of hemophilia B. Frequency is further reduced in patient of hemophilia B because of the more extended half-life of the factor 9 as compared to the SHL factor 9. This indicates durable long-term responses, more effectiveness of the extended half-life factor products as compared to the SHL factors. In patients requiring a surgery, single dose of the weight-based EHL factor 9 was enough to achieve hemostasis, but please don't conclude it completely. We should always keep the 2 doses. Remember this, if we are having only 1 dose, just with 1 dose we should not advocate this surgery. It may be effective, but it may fail also. So before taking up the patient for surgery, always ensure we have the enough supply of the factor 8 as well as factor 9. That is very important because otherwise we may land up with the complication of the patient. Future therapies, the way forward, future therapies like the non-replacement therapies also now coming, like emicizumab, poncizumab. These are also good molecule. Poncizumab is just in pipe, and I think within this year or next year it is expected to come in the market. The advantage of the poncizumab is that it has been introduced in a pen-like device, just like insulin. So it can be very easy to institute, and even in the home-based therapy basically. That is the advantage of the poncizumab. Emicizumab is also a good medication. But where used, it has special indication. It should be used particularly in hemophilia A with inhibitors requiring the prophylaxis. But now at various centers we have seen, you can say across India, they are routinely using it. Routine use should not be recommended for this study. Only special situation it's a good. Then last one is the gene therapy. Actually I told you because gene transfer, that is the only curative treatment available as of today, which is going to serve the purpose, but it is not, you can say, fully developed nowadays. So why the gene therapy? Because it is the only cure actually. Ideal prophylaxis, if we compare ideal versus the cure, so the gene therapy is going to achieve the cure. But it is not, you can say, fully developed now. It is not practically available, I will say. So this is the photograph of a person, Chris Bombardier actually, who is a person with hemophilia B. But he is on regular treatment and he is very active person. His life is, he is living a full life. That is, he is, you can say, he has climbed the Mount Everest also basically. So our purpose is just by showing this fellow that if a hemophilic person is on regular factor treatment, on regular monitoring, he can live a life like a normal person, and that should be our aim in hemophilic patients. Thank you very much.